Asthma is a long-term inflammatory disease of the bronchi and bronchioles, characterized by reversible airflow obstruction and bronchospasms. The inflammation causes thickening of surrounding smooth muscles and increases their contractibility. The early phase is initiated by IgE antibodies, released in response to triggers in the environment. IgE antibodies bind to mast cells that release cytokines such as histamine, leukotrienes, and prostaglandins. The cytokines make smooth muscle contract, causing airway narrowing. Over the next several hours during the late phase, eosinophils, basophils, neutrophils, and T cells migrate to the lungs, contributing to inflammation and bronchoconstriction. Which are triggers for asthma? A. Viral respiratory tract infections. B. Exercise. C. Gastroesophageal reflux disease. D. Thiazide diuretics. E. Repeated intubations. Common triggers are viral respiratory tract infections, exercise, gastroesophageal reflux disease, tobacco smoke, use of aspirin or beta blockers, environmental allergens, cold air. What is the pathophysiology of the airway obstruction? A. Basement membrane thickening. B. Smooth muscle relaxation. C. Inflammatory cell infiltration. D. Mucus hypersecretion. E. Vocal cord thickening. F. Smooth muscle contraction. The short-term effects are inflammatory cell infiltration, mucus hypersecretion, smooth muscle contraction. The long-term chronic effects are smooth muscle cell proliferation, basement membrane thickening, and collagen deposition. What are the typical symptoms? A. Palpitations. B. Dyspnea. C. Purulent cough. D. Wheezing. The typical symptoms are dyspnea and wheezing, which can be experienced as both expiratory and inspiratory. What clinical findings can you see? A. Peripheral edema. B. Wheezing. C. Crackles. D. Prolonged expiration. Some common clinical findings are wheezing and prolonged expiration when symptomatic. What are the possible spirometry findings? A. Irreversible reduced ratio of FEV1-FVC ratio. B. Reversible reduced ratio of FEV1-FVC ratio. C. Vital capacity slightly reduced. Possible spirometry findings are reduced FEV1-FVC ratio less than 80%, which is reversible after inhalation of short-acting beta-2 agonists. Vital capacity is usually normal or slightly reduced. What are the criteria for reversibility? A. 12% improvement in FEV1. B. 200 milliliter improvement in FEV1. C. 400 ml. The criteria for reversibility are 12% or 200 milliliter improvement in FEV1 after bronchodilation. What are the peak expiratory flow signs of asthma? A. 24-hour variability of at least 50%. B. 24-hour predicted value less than or equal to 80%. C. 24-hour variability of at least 20%. Peak expiratory flow is measured at home for 2 to 3 weeks, morning and evening, before and after bronchodilation. A 24-hour variability of at least 20% is indicative of asthma. What are the indications for a steroid test with peak expiratory flow and subsequent spirometry? A. FEV1 percentage of the predicted value less than or equal to 60%. B. Treatment-resistant asthma. C. Suspected asthma despite a negative reversibility test. When asthma is still suspected despite a negative reversibility test, inhaled high-dose steroids are given for weeks to months. What are the test results indicative of asthma for direct stimulation test or methacholine test? A. FEV1 decreased by 40%. B. FEV1 decreased by 20%. C. An FEV1-FVC ratio less than or equal to 90% after stimulation. Direct stimulation test results indicative of asthma. FEV1 decreased by at least 20% after less than 4 milligrams of methacholine. Treatment for asthmatic symptoms less than or equal to 2 times per month. A. Low-dose inhaled steroids when symptomatic. B. SABA before exposure to a trigger. C. LABA during periods of symptoms. D. SABA when symptomatic. Low-dose inhaled steroids and SABA as needed during periods of symptoms. SABA before exercise or allergen exposure. What is the treatment when there is insufficient effect from low-dose inhaled steroids and SABA when symptomatic? A. LABA daily. B. High-dose inhaled steroids when symptomatic. C. Daily low-dose inhaled steroids. A low to medium dose inhaled steroids should be taken daily, in addition to SABA and inhaled steroids when symptomatic. What is the treatment when there is insufficient effect from daily low to medium dose inhaled steroids and SABA plus inhaled steroids when symptomatic? A. LABA plus medium dose inhaled steroids daily. B. High dose inhaled steroids daily. C. Peroral steroids daily. LABA and medium-dose inhaled steroids should be taken daily, in addition to SABA and inhaled steroids when symptomatic. What treatment can you add when there is insufficient effect from daily LABA plus medium-dose inhaled steroids? A. Leukotriene receptor antagonists. B. Interleukin-5 inhibitors. C. Peroral steroids daily. D. LAMA. Leukotriene receptor antagonists, or LAMA, can be added to the daily treatment with LABA and medium-dose inhaled steroids. What treatment can be added when there is insufficient effect from daily LAMA, or leukotriene receptor antagonists, plus LABA plus inhaled steroids? A. Interleukin-1 inhibitors. B. Monoclonal anti-immunoglobulin E. C. Peroral steroids daily. D. Interleukin-5 inhibitors. Peroral steroids can be taken in short periods. Injections of interleukin-5 inhibitors can be given. For severe allergic asthma, injections every 4 weeks of monoclonal anti-immunoglobulin E, such as omalizumab, can be added. Like and subscribe if you want to see more videos like this. Check the description to see if this game is available for download. If you want to see more videos like this one, you can check out this video.